Hello everyone, a warm welcome to the latest instalment of the CDX Engage webinar series, hosted by Inivata, Circulating Tumor DNA to detect residual disease and recurrence in breast cancer. This webinar shall take you on a deep dive into the clinical utility of non-invasive assays for the early detection of residual disease and recurrence. My name is Fanula and I'm the bespoke event producer for CDX Engage, and I'll be chairing today's session. We have a fantastic speaker presenting to you today. I'm delighted to introduce Dr. Pedram Razavi, Medical Oncologist at Memorial Sloan Kettering Cancer Center. Good morning, Pedram. The webinar presentation shall last 45 minutes and will be followed by a quick interactive poll to let you provide your feedback on where residual disease and recurrence testing might have the most utility. This poll will be followed by roughly 10 minutes of audience Q&A. Please submit all questions via the questions tab at the bottom of your webinar dashboard. You can submit these at any time throughout the webinar. We will endeavour to answer all questions in the allotted time, and all unaddressed questions will be passed along to Pedram. So if we do run out of time, we can follow up with answers directly. Now, without further ado, I will hand over to Pedram to speak on ctDNA to detect residual disease and recurrence in breast cancer. Pedram, over to you.
Hello, everyone. Thanks for joining. Let me just share my screen first. Perfect. So thank you so much for joining. I'd be glad to talk to you about circulating tumor DNA to detect residual disease. Mainly, I will focus on the application of the ctDNA in breast cancer. So I'm a breast oncologist at Memorial Sloan Kettering, and my research focuses on breast cancer genomics and also development of liquid biopsy assays for breast cancer. So these are my disclosures. The relevant one is that I received institutional funding from GRAIL to perform some of the ctDNA studies that I present today. So I would like to just remind you that this is not a new concept. So Mandel and Mattei, 1948, a few years after the electron microscopy was introduced, started looking at body fluids and plasma, and they found evidence of circulating DNA in the plasma. They have a series of papers after this looking at every single body liquid and found some evidence of free DNA in all of those. So but the field was relatively silent until Dennis Lowe published his landmark paper on prenatal testing using cell-free DNA. And after that, the field picked up in oncology as well. And then now liquid biopsy has become part of our standard of care for some of the cancers. And we hope that we will be utilizing it more and more as we move forward. So just some clarification. So cell-free DNA refers to all circulating free DNA, includes normal and tumor DNA, and circulating tumor DNA or ctDNA only refers to the circulating tumor DNA. That's a tumor-derived cell-free DNA. So majority of the cell-free DNA comes from the normal cells, and obviously most of the tissue, even in cancer patients, is not cancer, it's normal tissue. And the amount of cell-free DNA and normal DNA very much depends on that tissue cell turnover. So higher proliferation and apoptosis rate increases the rate of cell-free DNA shedding from that tissue. Also, any cell injury, inflammation, autoimmune conditions, cytotoxic therapy, or impaired clearance can affect the amount of cell-free DNA in circulation. And this is important for interpretation of the cell-free DNA results when we look at cancer patients. I would like to just highlight this one paper from Dennis Lowe's group in 2002 when they looked at mismatched sex transplant patients, and they looked at the cell-free DNA in the recipient, and they showed very clearly by quantifying the amount of Y chromosome that most of the cell-free DNA actually comes from the bone marrow. And this was later also shown in the expression studies that majority of the cell-free DNA comes from the hematopoietic cells in normal non-cancer patients. So when we look at cell-free DNA, there are a few biologic features of it that we need to pay attention to. So one is that majority of the cell-free DNA and ctDNA sheds through apoptosis, but there are also other mechanisms like tumor necrosis, exosomes, and others that can also shed DNA and cell-free DNA into the bloodstream. The fragments are attached to the nucleosomes, and that explains the average size of the cell-free DNA, which is around 166 base pair. So 146 base pair of it is around the nucleosome, and then the rest of it is H1 linkers that are attached to it. And generally, the fragment size of ctDNA is smaller than normal cell-free DNA. And then we are getting more insight why this is happening. Probably has something to do with the nucleases. And it's also possible that cell-free DNA coming from the bone marrow or other major tissues that contribute to the circulating cell-free DNA actually have larger fragments than tumor DNA. So this is a field that has been going on, and fragmentomics is one of the hot topics in cell-free DNA biology these days. And also we can look at the fragment sizes and look at the expression profile of and tissue of the origin as well, mainly cleared by liver, but also some of it is cleared by kidney and circulating nucleases. And the most important thing is that it has a very short half-life. So in cancer patients who had complete resection and had serial cell-free DNA testing afterwards, it's been estimated the half-life to be around 15 minutes to hours. And one terminology that I will use, and there are different terminologies for it, but ctDNA fraction or tumor fraction is equivalent of tumor purity in the biopsy sample. It's just a fraction of the cell-free DNA that comes from the tumor. So cell-free DNA and ctDNA has been shown to be detectable in majority of the cancer subtypes, and very early studies of pan-cancer analysis of cell-free DNA showed that higher tumor burden and also the stage of disease is associated with the amount of ctDNA and ctDNA fractions. So the tumor, the more aggressive tumor with higher proliferation apoptosis rate, higher vascularities, and also the more aggressive subtypes, and also the site of the disease and tumor burden can affect the amount of ctDNA in circulation. So this was shown also in TRACERx study when they looked at the volume of the tumor and also the ctDNA fraction. And also in our analyses, we looked at the metastatic patients, and then we quantified the amount of and volume of the disease in a cubic centimeter based on the scans. And then we showed that in breast, lung, and prostate cancers, that the amount of the ctDNA fraction is very highly correlated with the disease burden. And these are the tertiles of the tumor volume. So as you can imagine, ctDNA is a very robust biomarker, and has multiple utilities. I will focus mainly on MRD, which is molecular minimal residual disease, also called RDR, residual disease and recurrence burden analyses. We think that this is one of the utilities that will affect our cancer care, hopefully very soon, and hopefully improves the cure rate for many of our patients. So when we talk about the assays, I'm just going to simplify this. So imagine that this is the iceberg is the genomic landscape of the tumor. So you can go wide, and then this is the genomic footprint of the assay, and we can go as deep as we can, and then we can find subclonal mutations, the rare mutations in the tumor. So the ones up here are mostly clonal mutations, truncal mutations that happen, that occur in majority of the tumor cells. So the assays that we can use whole exome, whole genome sequencing assays, usually these days using in this type of depth, and this provides us with a sensitivity of around 5% or so. And this is very effective in identifying the mutational landscape and clonality of mutations with higher allele frequencies, when especially in metastatic disease, when we can identify them using this type of assays. We can use this type of wide genomic analyses for mutational processes. We can look at the mutational landscape of the tumor, very effective in identifying copy number alterations, especially when the tumor ctDNA fraction is high. Also can be used for fragmentomics and tumor expression profile, and also monitoring disease clonal evolution, mainly in metastatic disease. But for de novo mutation calling, without any information from the tumor, this type of assays are not very useful when the ctDNA fraction is low. Another thing that is being used clinically is targeted panels with in silico and also chemical barcoding, and these are also have been shown to be very effective in identifying the actionable alterations and mutations of relevant in metastatic patients. However, these type of assays are generally limited because the size of the panel is relatively small, and also the sensitivity of this type of assays are often not suitable for disease in early stage setting. So broad application of cell-free DNA, especially for assessment of tumor mutational burden, MSI, monitoring tumor evolution and mechanisms of resistance, requires assays with a wider genomic footprint and the same type of sensitivity to identify more of the genomic landscape of the tumor. So for doing this, in collaboration with GRAIL, we developed an assay, and we tested this assay in 124 patients with metastatic breast, lung, and prostate cancer, and also 47 non-cancer controls, healthy individuals. We collected blood and tissue within 6 weeks of each other with no intervening change, and the cell-free DNA and matched white cell genomic DNA was sequenced using a 508 gene panel to a depth of more than 60,000x. Then their sequencing reads for both of them were assembled using a de novo assembly pipeline, and then SNV and indels were called. And then at the end, we had a joint calling and so a machine learning error collection model to finalize the mutation calls. Just some, when we looked at the mutations, we categorized them, whether they are germline, so we didn't look further into the germline alterations, whether they were biopsy matched or biopsy subthreshold. These are the mutations that had evidence in the MSK impact tumor assay that we had for these patients, but they didn't reach the clinical threshold for mutation calling. So we call biopsy subthreshold and biopsy matched tumor-derived mutations, and the mutations that were matched with white cells, and also some variants of unknown significance that were none of the above, and we call them VUSO. So the assay was very sensitive and specific. On the right-hand side, I'm showing one patient, hypermutator patient, using replicates. We have multiple replicates from the same patient, all of them showing very highly concordant results. This is the overall results, and then you see here less than 1%, there is very high concordance between the assays. So the assay was highly replicable. When we look at the mutation detection, and we are talking about the mutations that were found in the tumor and detection of them in the plasma, as expected, more clonal mutations that happen in the trunk, called clonal mutations that happen early on, they're more likely to be identified in the tumor, in the cell-free DNA, and it's consistent with the fact that majority of the cancer cells have these particular mutations, so the chances of identifying them is just higher. What was very striking in the cohort was that we had 10 hypermutated samples that they accounted for 60% of all the ctDNA mutations that we found in the plasma. And these 10 patients actually had much more mutations than the rest of the 114 tumors cases that we had in the cohort. When we look at the mutational signatures, for these cases, we've been able to accurately assess the mutational signatures. And this is what we expect with breast cases. With breast cases having apobic, mainly apobic signatures, something that is known to result in a hypermutated phenotype in breast cancer, and the lung cancer cases had smoking signatures and others. There was also this one prostate cancer case that had a very dominant mismatch repair signature. So that prompted us to do MSI analysis. We modified the MSI sensor and we did the MSI signature analysis, MSI score analysis. And then in the cohort, there was only one case, that one particular prostate case that was MSI high. Actually, this patient was enrolled based on the MSK impact results, and the MSI high detected an impact in a clinical trial of checkpoint inhibitor trial and had a complete response that maintained for many years. But then we focused on the sources of cell-free DNA. And what I'm showing here, it was kind of surprising to us when we saw this, that more than 50% of the mutations, even in cancer patients, originated from were matched with the white cells. And in controls, we've been expecting that, so majority of the mutations were white cell matched, and then we had some mutations that were VUSO, variants of unknown source. But in cancer patients, it was surprising to us when we hypothesized that this is probably, or these tumors, these mutations, somatic mutations, probably originating from clonomatopoiesis. And for those of you who are not familiar with clonomatopoiesis, these are clonal expansion of hematopoietic stem cells, and through the aging and also other processes such as treatment or radiation or other exposures, they are selected for or induced in the bone marrow. So for example, here, if you give a patient chemotherapy and there is a mutation in the stem cell that results in resistance to that particular chemotherapy, results in a founder effect, and then this particular mutation and particular clone will be expanded. And by aging also, some of them result in growth advantage of those stem cells, and those population of cells also expand by time. So this is a known phenomenon and is highly associated with age, usually affects some of the known leukemia genes, such as DNMT3A, TAPE2A, XS1, PPM1D, and so on and so forth. So we looked at the age association in our cohort, and white cell matched mutations were highly correlated. The frequency of these mutations were highly correlated with age. So this is age here, and these are the number of white cell matched mutations per case. And we did not find any association in the biopsy matched or tumor-derived mutations, and there was some small correlation in the VUSOs. And when we looked at the mutations, majority of the mutations were the canonical CH genes that were altered. But if you look at the list also includes almost every single gene that was included in the assay, including some of the known cancer tumor driver mutations. So majority of the mutations were the CH mutations, but also it affects non-canonical CH mutations. We think that majority of them are probably passenger mutations that accumulate in the bone marrow. Then we looked at the white cell sequencing data. So what I'm showing here is the frequency, a number of variants in the white cells. The darker shade shows if they are matched in the cell-free DNA or not. And here I show the allele frequencies of these mutations. And you see that when you look at the categories of age, there is a strong correlation with age, but within each age category, there is high variability, with some of the younger patients having more mutations, more CH mutations than some of the older patients, and the other way around. So it looks like that there is high variability. And the other thing that was very striking to us was that almost every single patient and also healthy individual had CH, telling us that if we sequence white cells deep enough, like we did here with a very high sensitivity assay, we should be able to find some evidence of CH in the blood. So the previous studies mainly used whole exomes with or whole genomes with a relatively low depth of sequencing, and that's why the CH studies showed the frequency only, CH only occurs in older patients with very small occurrence in younger patients. We think that that was mainly because of the sensitivity of the assays. In the white cells also, it was highly correlated with age, and also we found that some of these mutations, especially PPM1D, was highly correlated and associated with past exposure to anti-cancer therapy, especially radiation and chemotherapy. But what about the VUSOs? So these are the variants that we were not able to match them. And then when you look at them in the controls, in the healthy individual, most of them are actually look like to be residual CH based on the mutations. So these are probably the population of CH or subclonal CH that was not captured in the white cell or the DNA, genomic DNA from the white cells, or were not present in that particular tumor sample. And also, if you look at the controlled cancer patients as well, you see that majority of them are also CH, and some of them are known cancer genes, telling us that probably these can be both tumor-derived and CH mutations. And this is just looking at the variant allele frequencies in the white cells and the cell-free DNA. And you see here, when you look at these green VUSOs, you see that some of them follow the pattern of this white cell matched. Most likely these are CH mutations, and some of them, or majority of them, especially in the hypermutated cases, and some of the non-hypermutated tumor cases, follow the tumor-derived patterns, and most likely these are tumor-derived subclonal mutations that were not captured in the particular tumor sample that were sequenced. So this highlights the significance of doing matched normal sequencing to circulating tumor DNA and tumor-derived cell-free DNA. So, but what is the contribution of it? And so for this, we looked at the cell-free DNA variants with allele frequency of less than 1%. And you see more than 70% of these mutations are actually white cell matched. And again, highlighting, especially when we go to very high depth sequencing and then look at the mutations at the threshold of detection, that the contribution of CH can be very significant. And when we look at the other way around, when we look at the white cell mutations and the ones that were matched in cell-free DNA, we see that also in the white cells, majority of the white cells, around 40% of the mutations that were matched with cell-free DNA, also had the allele frequency of less than 1%. Telling us that we have to do some deep sequencing of the white cells, probably more than 1000x, depends on the sensitivity of the cell-free DNA. We have to sequence the white cells relatively deeply to be able to find some high quality reads to call many of, or cancel out many of these mutations, or filter out some of these mutations. So at the end of this exercise, we think that there was an advancement. This type of assays, larger genomic panels, provide an opportunity to look at tumor mutational burden, signatures, MSI, and also they can be highly useful in monitoring clonal evolution of the disease, identifying mechanisms of resistance. And also, I think the most important part was that our analysis showed strong evidence of CH as a biological phenomenon, and also a technical pitfall that can affect the mutation calling in cell-free DNA. And this is more pronounced in early stage disease when the ctDNA fraction is low, but also it's significant in metastatic disease even when the ctDNA fraction is high, as shown in our data in metastatic patients. We think for de novo mutation calling is probably, even with a large panel, is not suitable for screening, and also probably not suitable for MRD detection, mainly because some residual CH noise that can affect the calls and result in false positivity here. The detection rate is also at best is around 0.1%, or some of the other assays can be 0.05%, but this is probably not enough for calling mutations for MRD. And also, there are some sampling issues that some of these mutations may not be captured by the panel. So the panel can be completely off and just not detect the mutations that we are looking for. So when we look at the MRD assays and early detection of minimal residual disease, I would like just to show this and highlight that in metastatic disease, imagine that we have 30 nanograms of cell-free DNA, something typical entry for this type of assays, around 9,000 to 10,000. genomic equivalence. And you see that if the ctDNA fraction is high, there is multiple copies of mutants, so a relatively low sensitivity assay can detect a lot of these mutations. And then we go to 0.1%, 1% assays. These are the ranges that we see in metastatic patients. We still have multiple copies of the genome, and the current cell-free DNA assays should be able to detect them. But when we go to subgenomic equivalent, less than 1%, 0.1%, something that we see in early stage disease, because the volume and the disease burden is so low, we are thinking of clusters of tumors that shed ctDNA. This type of assays are not sensitive enough. And this is the analysis that was shown in the simulation done by Charlie Swanton's group, that majority of these mutations are actually not captured in some of the very sensitive fixed panel cell-free DNA assays available clinically. So there are multiple strategies to detect MRD in early stage, and most of them include combining different approaches. So combining the different approaches, including ultra-sensitive, fixed targeted panels, cell-free DNA methylomics that has been shown to be sensitive and specific in finding mutational signatures in some of the cancer types. So combination of these two seems to be sensitive, at least in some cancer types, including also whole genome, whole exome sequencing to look at mutational processes, fragmentomics, and also adding protein markers, and also more recently adding CTCs in addition to cell-free DNA to identify, to increase the sensitivity and the specificity of the assay. Some of the groups are working on enrichment of cell-free DNA, including for tumor-derived fragments. So we increase the amount of input DNA, but we select for ctDNA in that cell-free DNA input, and that will result also in increased sensitivity of the assay by increasing the ctDNA concentration. And also the assays that seem to be more promising at this point, at least for being used widely for different cancer types, are tumor-informed ctDNA assays. So I'm just going to show a workflow for a personalized tumor-informed ctDNA assay. So a tumor biopsy is acquired, or the resection of the tumor. It undergoes whole exome, whole genome sequencing, depends on the mutational burden expected for that type of cancer. To match normal is also sequenced to filter out CH mutations, and also call high confident tumor-derived variants. These go through a pipeline. Some of these variants based on the noise level in that region of the genome, clonality of the mutation, so on and forth, availability of the assay will be selected. A personalized assay is designed for the patient. Cell-free DNA gets extracted and then undergoes deep sequencing using UMIs and all the other techniques that we have for error correction, which seems to be very important for MRD detection. The benefit of this is that the threshold of detection, when we know what we're looking for, goes very high. So it can be as lower than 0.001%. The other thing is that we can increase the number of mutations that we are tracking because we know what we're looking for. So we are not limited to the panel of the genes that were included in the assay, and this we can include as many genes, as many mutations that are known for that tumor. And more importantly, because we look at smaller regions of the genome, the sequencing noise is less. And also the effect of CH is relatively minimal because we filtered them out at the beginning. So we are looking at only high confident tumor-derived variants. And some of the assays actually use the same assay on the white cells as well. And then if it also matches the white cell, they call them subclonal clonal autopoiesis, and they call them out. So the effect of CH and residual CH in this type of approach is relatively limited. So theoretically, you can increase the number of these mutations and achieve a very high sensitivities, like doing all exonic mutations or genome-wide exonic and intronic mutations. But the problem is the amount of noise. So this was suggested by Max Steen's group when they started, when they published their paper in 2016, that the amount of noise, as we increase the number of mutations that we're tracking, will be a limiting factor, and that turned out to be very true. They developed some methods for error correction Other groups also have developed multiple methods for error correction. We also developed one model based on analysis of the normal DNA based on a hierarchical Bayesian model of the healthy controls. And then we've been able to decrease the number of mutations and amount of noise by tenfold. So highlights the importance of noise reduction when we do this type of assays to minimize the amount of false positive rate in the assay. But what are the clinical evidence of mutational tracking? So this is one of the various studies done by Dr. Turner and his colleagues, and showed based on ddPCR following the known tumor mutations in breast cancer, that ddPCR monitoring of the tumor cell-free DNA can detect mutations with detect evidence of residual disease with very high sensitivity and with a hazard ratio of 12. So you see that majority of the cases that did not have ctDNA detectable did not actually have residual disease and did not have recurrence. They updated their analysis more recently, and as you can see, the updated analysis shows the same. But what is important is that seems like serial sequencing of the cell-free DNA and serial monitoring provides a better sensitivity and specificity, improves the negative predictive value and also positive predictive value of the assay. And you see that has a ratio of 16 or 17 here. It's something that is consistently seen also in other studies in other cancer types. It has a ratios around 10 to 50 based on the tumor type. This is a more recent analysis using the 16 gene panel, and you see that addition of the mutations provide better sensitivity of the assay. In this assay, they've been able to find evidence of MRD in ER positive, HER2 negative patients. So it was very significant for me because we've been thinking that luminal patients probably don't shed much of a cell-free DNA, but this was one of the first papers to show that these patients also can have detectable cell-free DNA, and also higher risk patients like triple negative, that majority of them have detectable cell-free DNA. And we see the same type of hazard ratios in this group as well. And more recently, now our colleagues at Broad looked at increasing the number of these mutations, and they looked at an assay that looks at up to 488 mutations, and you see that by increasing in the number of mutations in this cell line dilution studies, that they've been able to improve the sensitivity of the assay. Obviously, they included they included error correction models, and at the end, there is a trade-off by increasing the number of these mutations, not to affect the specificity of this type of assays, but they showed clinically that utility of this type of approach with large number of mutations improves the detection rate. And even with patients in the landmark analysis after 1 year, the 1 year cell-free DNA, if it was positive, it was highly associated with recurrence. And they showed here that the lead time is, in majority of the cases, is significant, probably allow us to provide escalation of care and try to eradicate the residual disease. But what was important was that in their analysis, they showed that the detection rate very much depended on the mutational burden and the sensitivity of the assay. So the patients who had evidence of MRD had a higher mutational burden and higher pre-test probability of detection. This is the work done by Nitz and Rosenfield group. So they published their data, their work on a method called INVAR. What is interesting about this method is that they bag all the informative. So this is a personalized assay, bespoke assay. They sequence the cell-free DNA based on the tumor data, and they bag the informative reads and non-informative reads. And then by doing them and not just looking for a specific mutation, they show that it can improve the sensitivity of the assay and also specificity of the assay very significantly. Also, what they did, which was, I think, was very smart, they used the assay for multiple panels from different patients in one run. So the mutations that are specific to one patient but not to the others, the negative reads from the other patients can act as control, artificially improving the sensitivity of the assay and also improve the noise reduction to call mutations. And they also showed that and predicted that when we use this type of approach, we can actually use tumor-informed whole exome or whole genome sequencing panels and just look at the informative reads. And by increasing the number of mutations, we should be able to call mutations with very low allele frequencies, and when the ctDNA fraction is less than 0.1% or so. This is a more recent study just published in Nature Medicine from our colleagues at Cornell. They looked at the whole genome approach, tumor-informed whole genome approach with sequencing depth of around 30 to 50x whole genome of cell-free DNA, and they showed when we increase the number of mutations to a genome-wide mutation rate, the sensitivity of such assays can very much improve. And they in a hypermutated or mutations in tumor cells with relatively high mutational burden, see that the assay performs very well, but they also showed in lung cancer and breast cancer, this type of approach can be very useful. I think one part of the study that I very much appreciated was the part on copy number and tumor-informed copy number analysis, showing that tumor-informed copy number analysis also results in detection of the tumor in cell-free DNA with relatively high sensitivity. This is relevant for tumors like breast cancer and others that are copy number driven tumors, and sometimes some breast cancers don't have enough mutations to track even when we do whole exome or whole genome sequencing. So this is definitely an improvement. The main problem with this type of approach, at least currently, is the cost of sequencing, and still whole genome sequencing is expensive and should be done on tumor, normal, and also on the cell-free DNA. The cost will limit the utility of serial cell-free DNA monitoring to identify MRD. So I think this is really good. It will be useful for some cancer types, but probably personalized assays at this point will be more useful, at least in short run. The other problem might be that this type of assays may also not provide enough information for when we would like to track multiple mutations. So at MSK, we developed a breast cancer liquid biopsy program in 2015, and we tried to identify and validate the utility of cell-free DNA in different settings. So we have a breast cancer program for early stage disease and neoadjuvant setting, and also for metastatic breast cancer. And we also have an autopsy study looking at serial cell-free DNA monitoring and also acquiring all the visible tumor sites at the time of autopsy through a warm autopsy to see how much of the tumor heterogeneity and clonal evolution can be captured by cell-free DNA. I will focus mainly on the first two studies. So one of the studies that we did is the cell-free DNA study. This was study started in 2015. We collected cell-free DNA pre-op and post-op from the patients, and then after adjuvant chemotherapy or radiation, if it was indicated. And then after that, we followed the patients every 6 months with cell-free DNA. And we are hopeful that this type of assays and the samples that are banked will be used soon with one of these high sensitivity assays for identification of MRD and assess the utility of this type of approach in breast cancer, especially when we look at different breast cancer subtypes in this large cohort of patients. Now, the study that we did is the neoadjuvant patients cohort that we looked at. We collected samples pre-treatment, on treatment, pre-op, after completion of neoadjuvant chemotherapy, and after that in follow-up. So the main thing that we're going to look at here is if ctDNA dynamics during neoadjuvant chemotherapy can assess the outcome of neoadjuvant therapy in terms of pathologic response, and more importantly, in this higher risk group of patients, whether it's ctDNA, post-op ctDNA, and also monitoring of it can assess can identify the patient MRD positive patients and assess the risk of recurrence. But at the end of the day, doing all of these studies, the goal is to identify the high-risk patients with direct evidence of disease in the cell-free DNA through liquid biopsy. And what we do now, we look at the tumor mutational tumor clinical features and sometimes genomic features of the tumor and identify high-risk patients, and we offer these patients chemotherapy or escalated therapy based on the clinical features. And we know if we don't treat any of these patients based on historic data, majority of these patients actually don't have recurrence. So we are certainly over-treating a large population of patients and under-treating a population of patients who probably did not respond to chemotherapy or higher risk require escalation of therapy. So the idea here is to use cell-free DNA and ctDNA liquid biopsy assays to identify MRD negative patients and candidate them for de-escalation studies, and also MRD positive patients for escalation studies, hopefully to improve the outcome of the disease. So the hypothesis is here that escalated adjuvant therapy in patients after curative intent therapy can result in ctDNA clearance. And we hope that this ctDNA clearance can be translated to an improved disease-free survival in this population of patients. We like to call this ctDNA clearance molecular response in this group of patients. So this is one of the study designs that you can have multiple tests or one test after curative intent therapy. The MRD positive patients will be randomized to intervention versus standard of care. The outcome of the study will be ctDNA clearance and also disease-free survival. ctDNA clearance will give us a very early read in the efficacy of the intervention, and also can allow us with collecting on-treatment samples to decide how many cycles of treatment is needed. Because here we are dealing with a disease with no visible disease. It's not like metastatic disease that we have CT scan or imaging to follow these patients and know how many cycles are required. So that also can give us some understanding of what would be the optimal duration of therapy. And also we can use this patient, use the MRD negative cohort for de-escalation study. So this is a study in triple negative high-risk group of patients post neoadjuvant chemotherapy, residual disease. These are the patients that we usually give them capecitabine. We can randomize them to an interventional therapy with escalated therapy and then compare it with capecitabine. And this type of studies can be done with a very small group of patients. So with 100 or less than 100 patients in this randomized group, we should be able to assess the efficacy of this, because we are dealing with a group of patients that have almost 100% risk of recurrence. So the positive predictive value of MRD positivity is very, very high. So the sample size here will be limited and small. So we are at the end of the day, we'll be able to do a very efficient clinical trials here. And we also use ctDNA clearance as an outcome. But ultimately, we can use this type of approaches after we do multiple of these earlier studies showing the efficacy of this for adaptive clinical trials and look at ctDNA outcome and as a ctDNA clearance molecular response as an outcome, and then try to do adaptive designs to improve the outcome of the patient. So this is just as examples, but you can imagine that each one of these arms, and also based on the molecular profile of the tumor, can also, and the ctDNA monitoring can help us identify the best treatment arm based on the categories, the pre-treatment category of the patient, improve the outcome in these patients. And then other types of studies that we do, and I think these are important studies and some of them are ongoing, is to show at the end the utility of the liquid biopsy monitoring in this group of patients. So we randomize the patients early on whether we want to monitor them with liquid biopsy or not, or versus standard of care. So the patients who get standard of care, they get liquid biopsy in research setting and will be analyzed retrospectively, but it will not be acted upon. And the other patients will have liquid biopsy testing, and the MRD positive patients will get the escalation of therapy, and MRD negative patients get standard of care, which is most of the time observation. And then we compare the outcomes of these two groups to show that liquid biopsy monitoring can actually improve the outcomes. Another important thing that is important, I think, makes MRD assessment put it beyond early stage disease is metastatic disease and the concept of molecular response in metastatic breast cancer. We've been using liquid biopsy in metastatic disease to identify actionable alterations and also look at the clonal evolution of tumor, but can be also used cell-free DNA monitoring as ctDNA monitoring to assess response and also escalate therapy. So this is a relatively small study of 50 patients who received alpelisib plus hormonal therapy in a phase 1, phase 2 clinical trial that we did at MSK. The study was positive. We had some responses, but this has been also shown in large phase 3 clinical trials. But what was important for us was that we did the monitoring of cell-free DNA. We collected cell-free DNA serially on these patients. And what I'm showing here is next-gen sequencing cell-free DNA assessment post-treatment versus pre-treatment, highlighting the role of PTEN that was suggested based on just one patient in from our group that can be a mechanism of resistance to PI3K alpha inhibition. And in this, our analysis very clearly highlighted the role of PTEN as a major mechanism of resistance for the patients who received PI3K alpha inhibition and alpelisib. Some of the patients had the mutation pre-treatment, and these are the patients that had a very rapid progression on the drug, and some of the patients acquired the mutations or probably had some subclones with PTEN loss that just expanded on therapy. We also found that ESR1 mutations pre-treatment can affect the outcome of this group. So again, what our analysis highlighted was that almost every single patient had evidence of evolution of disease based on ctDNA analysis. And this is an analysis of ctDNA mutations adjusted for tumor ctDNA fraction. So we either calculated the cancer cell fraction or adjusted the variant allele frequencies for change in ctDNA fraction in 2 time points, and you see that ESR1 mutations and PTEN mutations were major mechanisms of resistance, but there was also some mutations that probably were associated with better response to therapy. Combining this with also evidence that is being made from early monitoring of breast cancer in metastatic disease. So this is a study of LOMA-3 done by Dr. Turner's group showing that even cell-free DNA on day 15 can predict outcome in patients who receive CDK4/6 inhibitors plus hormonal therapy, in this case fulvestrant. And also in our analysis that I didn't show of the study, even day 7 ctDNA was predictive of response. And now there are more data recently presented in ESMO and others using next-gen sequencing also showing that ctDNA monitoring early on can predict outcome in metastatic breast cancer. And I think this provides an opportunity for us to design studies in metastatic disease and going for molecular response. So we give the patient standard of care therapy. We identify the patients with intrinsic resistance. So if we do early testing, or maybe we can do later testing with serial monitoring and identify the patients with acquired resistance or late resistance due to intrinsic factors. And then for the patients who have no molecular response, but they still have response or stable disease based on imaging, we can escalate the care and then randomize them to continuing standard of care versus escalation of care with addition of therapy or different therapy, and then have ctDNA clearance and also progression-free survival and overall survival as our outcomes here. So we are hopeful to see more of these type of studies. Obviously, these are tricky ones. We have to show that in early intervention can result in improved outcome in metastatic disease. I would like to argue that in breast cancer, at least, early intervention seems to, in majority of the cases, when it translates to improved progression-free survival, also it translates to improved overall survival. I'm just talking about, the recent CDK4/6 studies. Even when we gave the patients first-line fulvestrant versus AI in Falcon trial, the patients who received fulvestrant had a better outcome, telling us that probably hitting the tumor early when the tumor diversity is still not very high and decreasing the tumor diversity and achieving a better response early on in metastatic setting can also be translated, hopefully, to better overall survival for these patients, and hopefully improve the outcome for patients with metastatic breast cancer. So in conclusion, so liquid biopsy assays, I believe, that demonstrated very hopeful potential utility across a range of applications, and we are seeing the benefit of them in our daily clinical practice. Improving technologies will enable us to use these non-invasive assays and using liquid biopsies for personalized oncology, for MRD detection, monitoring disease, identifying mechanisms of resistance or early resistance or response, and also assessing the clonal evolution of the tumor. It is critical to understand the strengths and shortcomings of each cell-free DNA assay. So some of these assays, majority of the cell-free DNA assays inherently are have a low sensitivity for de novo copy number alteration calling and also structural variant calling. So this is something that needs to be considered. As we showed and also others have shown, CH constitutes a very significant biological phenomenon that needs to be considered in interpretation of the results, both in metastatic disease and also, more importantly, in early stage disease. And also, we should understand the tumor biology and clinical pathologic features that can affect the ctDNA shedding. So a treatment, a very effective treatment, considering the very short half-life of ctDNA, can decrease the ctDNA level to non-detectable ranges in days or weeks. So we should consider that also when we assess the cell-free DNA assays. And I think there is a very pressing need for design and execution of adaptive clinical trials based on liquid biopsy to establish the utility both in early stage MRD setting and also in metastatic setting. With that, I conclude. I would like to thank all of my colleagues at MSK and outside, and also I would like to thank our funding sources, and more importantly, I would like to thank our patients and their families. Without their participation, none of the studies that we do here at MSK were possible. Thank you.
Thank you for your presentation, Pedram. Please remember you can submit questions at any time via the question box. Before the Q&A begins in a few moments, we're going to run through a quick interactive poll. This will appear on your screens in a moment. What applications of residual disease and recurrence testing are you using or considering? For retrospective study, for understanding tumor biology and dynamics, for prospective use in the selection of patients for clinical trials, for prospective use for adaptive clinical trial design, for early readout of response, or do you have no current plans to use RDR testing? Thank you for submitting your answers. We now have some time for audience Q&A. So if you'd like to submit a question, please do so in the question box. The first question I have for you, Pedram, is how do you see these approaches to detect RDR being applied in clinical practice?
So as I mentioned, I think we need to do the trials first. And I'm happy that some of these trials are being designed or already running in breast cancer and also in other cancer types. I think we need to first establish that escalation of care in early stage setting based on MRD can improve the outcomes of the patients. We start with disease-free survival and then we assess the overall survival. And then after that, I think we should start using many different approaches to try to eradicate ctDNA. So the good example, I'm a breast oncologist, and then we use neoadjuvant chemotherapy all the time, and the outcome of neoadjuvant chemotherapy pathologic complete response has revolutionized the way that we do studies in early stage breast cancer. So having a pathologic response is a surrogate of disease-free survival and response of the residual disease that has already escaped the breast. But if you have a direct evidence of residual disease using liquid biopsy assays, that's a direct evidence. We can just monitor that and see if the tumor is responding or not, and then we can escalate or de-escalate care using this type of approaches. So I think there is definitely a pressing need to do the studies. In routine clinical practice, we don't use that, and it's mainly because the current cell-free DNA assays that are available clinically, and I'm talking about the assays that are designed, fixed panel assays for identifying actionable alterations and have utility in metastatic disease, have very low sensitivity in MRD setting, and also have high false positive rates. So we don't use them in clinical practice, but we are looking for clinically available MRD assays, and I will offer them to some of my high-risk patients as soon as they become available.
Mm-hmm. And the next question is, how soon after surgery and then how frequently should these tests be repeated?
So this is a very good question, and this definitely depends on the type of disease. We usually wait for a couple of weeks after surgery to collect the first cell-free DNA sample, and this is because usually there is some normal tissue damage and inflammation from the surgery, and amount of normal cell-free DNA goes up, and that results in decrease in ctDNA fraction. So we wait for a couple of weeks to collect the first sample from the patients. This is obviously much less significant in breast surgery that is mainly very non-invasive therapy, but even in breast surgery, we see some increase in normal cell-free DNA after. And then after that, it depends on the setting. So for the patients who received neoadjuvant chemotherapy before, and they will go for observation, I think we should collect the first sample post-op, and then after that, based on the disease subtype, we should monitor these patients frequently. So for triple-negative breast cancer, high-risk breast cancers that often tend to recur early, this could be every 3 months or every 6 months, and for higher risk patients, 2 to 6 months. But for lower risk patients, some of the patients with lower risk of recurrence or late recurrence, like luminal A type of breast cancers, this can be done less frequently. And also this can be used even years after to identify patients with late recurrence. So we look at patients with luminal breast, ER positive breast cancer, and they have a risk of recurrence even 20 years after, or even more after disease diagnosis. So this type of approach can be part of routine follow-up of these patients, and also can be used, hopefully, I anticipate that we're going to have trials showing this, that we can use this for extended adjuvant hormonotherapy for these patients. So we continue the therapy, the patient has negative cell-free DNA. At the end of 5 years of hormonotherapy, we can just monitor the patient and either offer or don't offer hormonotherapy based on ctDNA results. I think it very much depends on the setting. In adjuvant setting also, it is a little bit more tricky. It depends on whether we want to use ctDNA to escalate or de-escalate care in the patients, or so if that's the case, we should do post-op before they start adjuvant therapy. But if we want to look at MRD and serial monitoring for escalation of care after the patient received standard curative intent therapy, it should be done after chemotherapy and radiation if it's indicated.
Thank you, Pedram. And I think we've got time for just one more. The question is, are there particular tumor types where these approaches are more likely to be used?
Yeah, so very good question. The ctDNA shedding very much depends on the breast cancer subtype and the aggressiveness of the tumor. So I expect the early studies to be done mostly in triple-negative breast cancer. These are more aggressive types of breast cancer, higher rate of recurrence. And also the time to recurrence, the disease-free survival is generally shorter. So these are type of studies that can use the utility of MRD detection for curative intent, after curative intent therapies. And then I hope to see also now we are all disappointed with Palace clinical trial didn't show, it wasn't significant, at least as far as we know at this point, pending the subgroup analysis. But I think this type of approach can also be used to identify patients for escalation of care in ER positive, HER2 negative group. Also for the HER2 positive group patients, we are escalating the care, giving them TDM1 after therapy. So there is definitely an opportunity to use this type of approaches to improve outcomes even further for the patients who have high risk features after neoadjuvant therapy. So the outcomes with addition of TDM1 in HER2 positive group is so good that running clinical trials showing efficacy of another drug require thousands of patients. So hopefully this type of approaches, selecting very high risk of group of patients, allow us to do more efficient studies directed to this high risk group of patients and show efficacy of experimental drug compared to standard of care for these patients. So I think there are many approaches. I think it's going to be triple negative in short answer. I think it's going to be triple negative as the first set of studies that will be resulted, and I hope to see it for ER positive and HER2 negative, HER2 positive disease as well.
So thank you so much to the audience for submitting those really great questions, and thank you, Pedram, for your answers and earlier presentation. So that's all we have time for, and I hope you enjoyed the session. All unaddressed questions will be passed on to Pedram. Please look out for an email from us tomorrow. We'd love to hear some of your feedback on today's webinar, and this will also contain some information on accessing today's presentation. If you do have any follow-up questions or comments, please email them to info@hansonwade.com. On behalf of CDX Engage and Inivata, thank you so much for your time. I hope you enjoy the rest of your day and hope to see you again next time. Thank you.